Ow! Ow!
Sige, sakit daw ka. Kasi makasakit.
Takot ako ng ulo, no?
Sa radiate ang
Sa ano, medyo orbital. Sa mga mata, pero trigger sa
Ano sa nagsubo?
What are the important things to note when taking the history of a patient with headache? Headache is one of the most common reasons for seeking medical help. It is highly essential to assess the patient properly. In approaching a patient with headache, the physician is highly dependent on the cooperation of the patient for a reliable history. The first step of the clinical encounter is to enlist trust and cooperation and make the patient realize the importance of the history and examination procedures. Special care must be taken to avoid suggesting to the patient symptoms that one seeks. The patient should be discouraged from framing symptoms in terms of what may have been heard or searched on the internet. If the cooperation of a patient is possible, such as those having cases of coma, confusion of a young child, an attempt should be made in order to acquire the necessary information from other sources. History taking comprises many parts, but we should focus on the history of present illness, past medical history, family history, and the personal and social history. As we go over the patient's history, it is important to take note of the characteristic of headache. This is a crucial time for the physicians to clarify the attributes of each symptom that will aid in narrowing down differential diagnosis pertaining to headache. According to Bates, there are 7 attributes of a symptom, and these are location, quality, quantity or severity, timing, onset, aggravating factors, and associated manifestations, which will determine the diagnosis more often than will the PE or imaging. The location is helpful to determine if the headache is generalized or localized in certain areas, such as those in the occipital, frontal, temporal, and parietal regions of the head, as well as other areas such as the neck, the eyes, and sinuses. It is also important to note whether the sensation is unilateral or bilateral. The physician can ask the patient to point the areas of pain or discomfort. Knowing the site of the headache will help you identify the type of headache that the patient is experiencing. For example, cluster headaches, which are orbitotemporal and unilateral, while tension-type headaches are more generalized. It is also important to determine the radiation and ask the patient if the pain stays in one place or not. For example, tension-type headaches radiate bilaterally from the top of the head, going to the back of the head, and going to the neck. If the pain radiates to the neck, it may be associated with meningitis. If the pain radiates to the eye, it may be associated with glaucoma. Next is quality. The quality of pain is essential to the diagnosis, but the sensation may be difficult for the patient to describe. The quality of a pain may be tight, such as those in tension-type headaches. It can be aching, pressure, burning, bursting, sharpness, or stabbing. A pulsatile headache usually implies a migraine. One must keep in mind that the patient may sometimes use the word throbbing to refer a waxing and waning of the headache without any relation to the pulse, and is used to transmit the severity of pain. For the severity of pain, we must note that this is inherently subjective and reflects patient's temperament, attitude, and pain tolerance. We can also ask the patient to rate the pain scale from 1 to 10, 10 being the most painful and 1 being the least. A useful index for the severity of the headache can be taken when asking the degree to which pain has incapacitated the patient, if pain has awakened or prevented the patient from sleep, or there are autonomic reactions such as sweating or tachycardia. Next is timing. To gauge the temporal pattern of the headache, try to be as detailed as possible when eliciting information. Ask when the headache appears or disappears and worsens or improves throughout the day, or when the pain is worsened or terminated by sleep. In determining the onset, it is important to let the patient recall when the headache first started. Did it develop gradually or rapidly? Was it persistent or intermittent? Several questions about the onset can also be helpful, such as how did the pain evolve over time? How often does it occur or recur? How long does it last? Here are some types of headache accompanied by its onset. Identifying the precipitating, aggravating, or relieving factors can help in differentiating diagnosis of headache. Premenstrual period headaches are usually generalized and mild in degree. It is also important to take note that migraine attacks can also occur at this time, also known as catamenial migraine. Headaches of cervical spine origin occurs after an intense period of inactivity such as night's sleep. Neck may feel stiff and pain when moved. Infection affecting the nasal sinuses can also cause headache that may appear upon awakening or mid-morning and worsens due to stooping and changes in atmospheric pressure. Prolonged reading and exposure to glare of video displays can cause eye strain and may be associated with head pain. It is transient, therefore not considered an important cause of headache. Bursting or thunderclap headache lasts for a few seconds to minutes, and this can be caused by alcohol, intense exercise, stooping, straining, coughing, and sexual intercourse. Headache of intracranial source is made worse by sudden movement, coughing, or straining. Migraine occurs several hours or a day following a period of intense activity and stress. Pain when the scalp is stroked, such as coming or allodynia, is common in migraine. It could be a symptom of temporal arteritis. Headache can also be caused by vasodilator drugs such as nitroglycerin, dipyridamole, and monosodium glutamate. Excessive intake of alcohol or concussion headache are also common. Obtaining past medical history is important, as this might be the cause of the headache of the patient. In diseases such as those in inflammatory disorders, past infectious episodes, post-traumatic injury, iatrogenic injury, and medication overuse. In family history, many neurological disorders have an underlying genetic component. More detailed questions about family history are often necessary in polygenic disorders such as migraine. For the personal and social history, it is important to inquire about the history of a drug use, both prescribed and illicit. Asking questions about environmental or industrial exposure to neurotoxins may also provide essential clues. Temporal profile. Today, we'll be talking about its 7 types. Let's start with migraine without aura. A common migraine located at the frontal temporal lobe, characterized by pulsatile throbbing and bursts behind one eye or ear, usually occurring upon awakening or later in the day. Its provoking factors are bright light, noise, tension, and alcohol. Another location that is affected by this type is either unilateral or bilateral, which the pain becomes dull and generalized. In most cases, it has a 4 to 24 hour duration and sometimes longer. It is relieved by darkness and sleep. Next type is migraine with aura, a neurologic migraine located at the frontotemporal lobe, characterized by scalp sensitivity with the same diurnal pattern and provoking factors as the first type. Another location that is affected by this type is either unilateral or bilateral, which is associated to family history. Some features to look out for are unilateral paresthesias, weakness, dysphagia, vertigo, and rarely confusion. The third type is described as histamine or migrainous headache, located on the orbitotemporal lobe. It has an intense, non-throbbing pain that has a nocturnal pattern usually occurring 1 to 2 hours after falling asleep. This type is provoked by alcohol intake. This type also affects the brain unilaterally, and it is occasionally diurnal, associated with stuffed nostril. For the fourth type, we have tension headache, which has a generalized pain distribution. It is characterized by non-throbbing, tightness, and aching pain, which varies between patterns of continuous, variable intensity for days, weeks, or months, and is provoked by fatigue and nervous strain. The next type is meningeal irritation, that can be caused by meningitis or subarachnoid hemorrhage. The general area of the brain can be affected, but is also common at the bioccipital lobe and bifrontal lobe. It is characterized by a rapid evolution of intense, steady, and deep pain that may be worse in the neck. It is associated with neck stiffness and forward bending, Kernig, and Brzezinski sign. The sixth type is brain tumor. This has unilateral or generalized location with variable intensity to the point of awakening the patient, or steady pain that can last from minutes to hours, which becomes worse and increases intensity early in the morning. It is associated with papilledema, vomiting, impaired mentation, seizures, and focal signs. The last type is temporal arteritis, which has a unilateral, bilateral, and temporal location. It is characterized by throbbing, then persistent aching and burning with arteries, thickened and tender, and has an intermittent to continuous pattern which persists for weeks to months. It is associated with loss of vision, polymyalgia rheumatica, fever, weight loss, increased sedimentation rate, and jaw claudication.